Happy 2025 MCAP. Let's jump right into it. Team, I need 1 year. I need 1 year for you to allow the following to be worked on and done that you see on this slide here. Let's go over it very quickly. I need your support. I need for you to stick in here with me 1 year. Let's do it this way, and then let's reassess where we come out. Treatment protocols. We need to work on charting and billing all meat services. We'll deal with that here on the next couple of slides, but the team should know what meat means. We're going to stop doing opioid and benzo combo prescribing, starting with our Medicare patients. Pain management appointments will be done by themselves. Weight loss appointments will be done by themselves. Appointments for chronic conditions will be with 3 or less chronic conditions, 5 stable conditions or less. When there's a hybrid of stable and unstable conditions, 3 conditions or less. A patient who has 2 or more gaps will have a gap closure or focus appointment. We're going to be launching chronic care management effective January 2025, so we need your support. And the proper use of telehealth. Coding accuracy. Want to make sure that we're properly using the term medical stable and make sure our medical standards are aligning. We're going to talk about 99213 undercoding. There will be a renewed focus on quality and gap closures. Treatment plans per disease state, especially in unstable patients. The proper use of appointment types and coding review sessions with our billing company led by Amy. Staff accountability. Healthcare providers, we're going to do more quality and gap reviews one-on-one with you. There are some new regulations around nurse practitioner chart reviews that we'll be enacting. Timely performance coaching across the board with all staff members and working from the perspective of growing teammates, transitioning teammates to positions that they're more successful and have a stronger aptitude and acumen for. And if we cannot get staff members to level up to the requirements, we may have to replace staffing. This is a big one. There's a 2.83 decrease from 2024 in Medicare reimbursement. 2.83. Primarily driven by, it says a small adjustment, but I can show you where it's not a small adjustment, by what's called our relative value units, RVUs. Again, this is a refresher for the majority of this team. We've talked about RVUs the last 3 meetings, and we talked about the fact that if healthcare providers did not do a better job, not just MCAP, healthcare providers overall, did not do a better job of documenting what they're doing with patients, that Medicare was going to start cutting, and they did. To the left is the formal definition of RVUs, but let me put it in layman's term. It's really knowing if a patient is stable or unstable, creating a treatment care plan around that, considering everything that a healthcare provider is doing for that treatment of that patient, and healthcare providers are considering everything that their medical assistant or other qualified health providers are doing, and creating an RVU through CPT coding that reflects the proper charting, medical decision making, time spent with the patient, time spent preparing for the patient, and all of the above. That is what an RVU and how it's calculated. We previously talked about MEET. That's when you monitor, evaluate, address, or assess or treat a condition. I want to restate our company policy. Any staff member who performs a MEET-related medical service is required to chart the MEET medical service provided and to properly bill those MEET services when appropriate. In brevity, and I have an example like this for every single provider. The summary of this patient is consistently this patient calls right after an appointment and asks for something else that we don't chart nor do we bill, including most recently, we started a medication 3 days after the patient's last appointment, did not update the problem list, did not properly chart it, sent in a medication without billing for it, and this causes huge liability. We also sent in 3 different referrals on 3 separate times. We sent in the same referral 3 separate times for this patient, and the patient still has not gone to psych. Over 29 non-billable services provided to this patient, 6 cancellations, 1 reschedules in less than 2 years. Only roughly 8%, not only, roughly 8% of our current MCAP appointments qualify for or meet the standard of a 99213. However, we had over 6,000 undercoded 99213s. Those are just the ones that our billing company and our coders have been able to be identified as undercoded in 1 year. 6,000 undercoded ones. We need to re-engage our medical decision-making chart and remember that it's 2 or more self-limited minor problems, only 1 stable chronic illness, or 1 acute uncomplicated illness or injury qualifies. By definition, even in that scenario, if you go over 29 minutes with a patient, by definition, it is not a 99213. So these appointment codes, we should never be putting a 99213 for these appointment codes. Similarly, an unstable chronic condition is not a 99213 by definition, let alone when you add 1, 2, 3, 4 non-self-limiting additional ICD-10 codes to the patient. So let's make sure we're all using the proper definition of stable. We're going to go through that on January the 10th, but unstable chronic conditions by definition are not a 99213. Pain is not a self-limited or minor condition. Therefore, it is not a 99213, especially in addition when you have 3 or more. Again, this report only allows 4 ICD-10 codes to be shown. However, the majority of these 99213s has 7 or more ICD-10 codes associated with them, 9 or more medications. So we have to address it. We've worked on it for 2 years in a row. Coders will hold all undercoded 99213s for a weekly review with the healthcare provider. If the 99213 is appropriate, it will be sent through. If it is not, then we're going to hold it. The coders are going to flag it. It will be held. A coding team will review it. We're going to start weekly. Then we will go to bi-weekly or monthly. Then we will go with quarterly. However, we have to get our 99213 undercoding under control. Healthcare providers, please get with Nikki on which day of the week you would like this process to start. There are more than enough ways for providers and staff members to know where the real focus is. This is directly off the Provider Access website with Blue Cross Blue Shield. But there again, we know blood pressure, screenings for cancer and colon, diabetics, and our medication reconciliation. It hasn't changed. This is what we give snapshots for and the pop health reports for. So Nikki, Zachora, and Ebony have done a great job of letting us know who we should be targeting. However, there still are some opportunities. An example of an opportunity is MCAP has 5,170 patients with diabetes. That's the column. That's the report to the left. The report to the far right shows that we have 189 patients with an A1C multiple times over 8.1, which is the threshold, including some patients well over the 13, where it stops at 13. Whether or not it's 5,170, or 189, we only did and recorded 90 diabetic eye exams, 16 blood glucose finger sticks, with either 5170 as a base number for you to consider, or patients with double-digit A1Cs or uncontrolled, unstable A1Cs, 189 of those patients. So our diagnostic testing for diabetes is not matching our patient population. I need your help with that. Side note, we spent over $8,000 last year on COVID tests. Over 8,000. We had 319 combo COVID flu RSV tests, 148 rapids, 125 flu, 153 strep. There's over $5,000 of missing COVID tests based off of that number. 5,000 COVID tests roughly equates to $20,000 of billing. So there's a miss of more than $25,000 in COVID testing alone. Now, I by no means think that somebody has stolen $5,000 worth of COVID tests. What I'm thinking is we're not putting the COVID tests inside the system and getting paid for them. So our diagnostic test ordering process overall, we're going to talk about it on January the 10th. We have to figure out something. We have to do something different in 2025. Similarly, this is from Blue Cross Blue Shield. The upper left-hand corner shows that we have an outlier performance in our lab services. The middle chart graph that has the green bar line, then the blue line, then the black line. The green line is our performance. The blue line are other healthcare providers in our community. We're double. We're double, but as the two charts on the bottom, one's Dr. Herples, one's Dr. Bannock, we have a ton of red, which is bad, including A1Cs. So we're doing twice as much lab testing for not as good of a result as we would have expected. So, January the 10th, we're not reviewing anything that I've covered today. Please stop the video, go through it at your leisure, where you can actually look and kind of dissect the charts, the slides. January 10th is a lot less Derek talking. I want to hear from this team of how we do things better and more efficient in 2025. Example, for 5,170 diabetic patients, almost 200 patients with out of control A1Cs, how many diabetic blood glucose sticks should we be doing, and on what patient? How many EKGs should we be doing, and on what patient? These are same thing for spirometry. I need your help in figuring out how to be more effective in treating patients, recording that treatment plan in the patient's chart, and when providers and other qualified healthcare providers, such as our MAs, are providing services to patients, reducing our liability by properly charting and billing for those services. That's where we have to be in 2025. That's what I'm asking for your help to do. I need 1 year to prove that this plan can work. So I need for everybody to come on January the 10th with open minds and recommendations and solutions and input. I look forward to seeing everyone then. Have a great weekend, and I will see you all Monday, January the 6th, the Lord willing. Thanks so much.